Good afternoon. I'd like to welcome everybody to this afternoon's committee meeting of Adult Health and Social Care. My name is Jo Lawson and I'm the chair of the committee. If we could have a round of introductions from our panel members, please.
Thank you, Chair. Councillor Eric Firth, Dewsbury East.
Hello, Kim Taylor, Voluntary Co-op-T.
Hello, Councillor Alison Munro.
Councillor Tim Bamford, Denberdale.
And we've also got online Helen Clay. Are there any apologies?
Apologies received from Councillor Lowe.
Thank you. If we can move on to the minutes of the previous meeting, is there anybody to move those that they are a correct record? That would be me and somebody else. That's lovely. Any matters arising from the minutes? And moving on, have we got any declarations of interest? If I could just, I hold a bank contract with CHFT.
I'd just like to declare a other interest. Thank you.
And all items on the agenda are open to the public yet? Do we have any deputations or petitions?
None received, Chair.
Any public questions?
None received, Chair.
Okay, if we can then move on to the first item on the agenda, which is joined up hospital working.
Thank you. And just by way of introduction, my name's Len Richards. I'm the Chief Executive of Mid Yorkshire Teaching Trust. A colleague from...
Hello, I'm Anna Basford. I'm Deputy Chief Executive at Calderdale and Huddersfield Foundation Trust.
Hello, I'm Catherine Riley. I'm Associate Director of Strategy at Calderdale and Huddersfield Foundation Trust.
So thank you. We've put a presentation in the pack. I wasn't intending going through that slide by slide. I just wanted to take a brief time at the beginning, maybe just to introduce the work that we're doing together, and then we're happy to open up to questions for the panel. So the relationship between Mid Yorkshire and Calderdale and Huddersfield has been a good, positive relationship over a long period of time. Anna was just telling me 2016 was the first time there was an MOU, a Memorandum of Understanding, between the two organisations around collaboration and the delivery of services. And I guess that's a really positive thing given the nature of Kirklees and the population of Kirklees, which is served by both organisations, predominantly through Dewsbury for us in Mid Yorkshire, but also the Huddersfield Royal Infirmary here within Huddersfield. So that started as a memorandum of understanding, and there have been elements of work that have been done pre-pandemic around fertility services, around microbiology. There was some work done around bariatric surgery, etc., looking to see how the two organisations could work together to provide a more joined-up service and a more sustainable service for the population of Calderdale, Kirklees and of Wakefield. We all know the pandemic was a real challenge for us within the NHS, and a lot of those arrangements, I guess, were put on hold as the NHS responded to the pandemic. But we decided, under new leadership, myself coming in for Mid Yorkshire, I joined in 21. Brendan Brown came in to Calderdale and Huddersfield just after me, towards the end of 21. Beginning of 22, and we got back together to sort of say, how do we reinvigorate this partnership, because it's clear that we need to be working together to provide more joined up services. So what we did in early 22 is we created what we've called a partnership board. That's a formal part of our governance. We meet monthly. It's chaired by myself, 1 month, and the second month by Brendan, and then back to me on the month after that. And we're identifying areas where it would make sense for us to join up the delivery of services. We've got quite a significant agenda. Non-surgical oncology is probably one of the highlights of that we've been working through over the last couple of years. We've also worked together on maternity services, and the Overview and Scrutiny Committee here in Kirklees has had presentations and joint presentations by our frontline clinicians around maternity services. We've worked quite closely together on the development of community diagnostic centres. In the design and the development of that, we have established a CDC within the Wakefield community, and the Huddersfield CDC is to come online in around about 18 months' time. But the development of that has been done jointly. We understand the care pathways that we're establishing as a result of that. And then just more recently, we've developed joint leadership of our digital offerings. So Rob Burkett, who is the Chief Digital Information Officer within Calderdale and Huddersfield, is now doing a shared post whereby he's also the Chief Digital Information Officer within Mid Yorkshire Teaching Trust. So he reports to me and to Brendan, which is can cause complications, but having said that, because of the nature of the relationships that exist, it isn't causing any complications. And actually, we've seen in the Mid Yorkshire side of the partnership, our digital development significantly increase and improve as a result of Rob Burkett's leadership. So as a model, we're looking into more of those sorts of things to say, how can we work together? And I guess the digital side of things is an important one to talk about, because often digital systems are a barrier to integration, or digital systems are a barrier to where the location of services are provided. If you're seen in Huddersfield and then transfer to Mid Yorkshire, you're on a whole new digital system to transfer across. Whereas what we're looking to do through this partnership is harmonise our digital systems going forward, and Rob is leading on that. I guess just to sort of round off in a sense, I've talked about what we've done, that the relationship has been a long-standing one, that relationships are good, that we're talking about the Kirklees population as a Kirklees population rather than when I first arrived, which was in Mid Yorkshire. We talked about North Kirklees, and I know within CHFT it was the Huddersfield and Greater Huddersfield population. We're talking about Kirklees, and we as providers are coming together to say, well, how best can we provide that for the population? And I know that was very welcome from the local authority, and I know that's been commented on, that over the course of the last couple of years there's a much more joined up offer going forward. I think just to signal, there's a lot more to do in this space. I think there's a lot more areas other than the ones that I've talked about where we should be working more closely together. And Catherine's just been appointed, as she's described herself, as the Director of Strategy and Planning, but she's also been appointed to lead on the partnership board on behalf of myself and Brendan. And part of the work that's being done over the course of the next few months is what is the scope for greater working together so that we can provide more joined up services. So that we're developing that, and at a point in time over the course of the next 6 months we'd be quite happy to come back just to talk about where we think there is greater opportunity for us to work more closely together going forward. So that was all I was going to say. I don't know, Anna, if there's anything you would want to add to that, or Catherine, if there's anything you'd want.
No, fine.
So open up to questions really, and happy to answer those as best we can.
Thank you for the presentation. You were saying that the diagnostic unit has actually opened in Wakefield?
Yes.
When did that actually open?
So it opened, I think, probably 2 months ago.
is, and for there are a number of new members of the panel, could you just explain what kind of tests we'll actually be doing in that centre?
Yeah, so it's a community diagnostic centre, so diagnostics in a building in the community, so not in the hospital site, but we are able to offer MRI, CT, plain X-ray, ultrasound, phlebotomy, so blood taking, and testing, and then there are some other more specific specialist diagnostics around ophthalmology, so eye, macular degeneration, diagnostics, and there's just some other more specialist areas as well, but the mainstream is the imaging and the phlebotomy.
Thank you. I was actually going to ask you about the macular degeneration. So it is just basically fundus photographs, OCT,
That's
vision,
right.
and
That's
that
exactly
type of thing. Sorry, that's
your
my,
area.
That's my background.
And it's not mine, so so thank you.
It just piqued my interest there.
Yeah.
Sorry, Helen, did you want to come in? Kim, oh, sorry.
No worries. Yeah, my query was just more about digital working. So is the object of the exercise to get an aligned, the same system between Calderdale and Mid Yorks? And also how does that interface with primary care and not necessarily also GPs, but the community organisations, so community nursing, to improve patient care, because that's often a big barrier in my experience.
So I agree with that. I think the first part of your comments are right. The aim is to align our systems so that we're working on the same system between the two organisations. Part of the non-surgical oncology work has been a tender of a new system called Chemo Care. That's being put in, and we will have the same instance of chemo care in the Mid Yorkshire Trust as well as the Calderdale and Huddersfield Trust, which means data gets entered once wherever, and the patient can transfer between the two organisations. We're looking to do that on a much bigger scale around the electronic patient record. That is subject to a business case because there is an electronic patient record at Calderdale and Huddersfield. We would like to join that.
Right.
And we're submitting our business case through to the department. It's been submitted, it's going through regional office at the moment, and we're hoping to get some answers back on that in October. The bit that I'm hesitating a little bit, and Catherine or Anna might be able to help me here, is around that link with the community.
Yeah.
Clearly, Cerner and the system itself does have a sort of the ability to capture information in community settings. We've got a complex sort of infrastructure across Kirklees, Calderdale, Kirklees and Wakefield. Mid Yorkshire provides community services for Wakefield and District. Locala provide that for Kirklees, and CHFT provided for Calderdale. So we would, I think that it's probably a second iteration and a second development to understand how communities play in a consistent way around that.
Okay.
Just on that point, at Calderdale and Huddersfield Foundation Trust, we implemented the electronic patient record in 2017, so we've had a bit of time to develop how we optimise the use of that, and a key part of that has been about the interoperability, as it's referred to, with primary care systems. So we've done work with local GP colleagues about how can we utilise the function that enables us to view appropriately the right live and up-to-date clinical information that supports the delivery of care, so that patient, the accuracy and the knowledge that's needed to deliver the care, but also so that patients don't have to repeat the same information, or indeed if they're not able to repeat that information. So the functionality is there within the system that we currently have at CHFT, that is looking to be implemented at Mid Yorkshire Hospitals Trust, and therefore the potential to optimise that with primary care colleagues is there as well. And it's not about seeing all aspects of all records, but it's about seeing those key things with that help to support and keep patients safe.
So just on the back of that, my last question, just about the laboratory work. So will that mean that technically, or you might not be able to answer this, but centralised blood service is provided by Mid Yorks, and then Leeds providing microbiology for the 3 organisations. So would that mean that a GP would have to log on to 2 different systems, or is the aim for one central portal?
So
just to clarify.
The aim of the laboratory system is that we are procuring a laboratory information management system for all of West Yorkshire.
Great.
And that would key in all of the organisations. So CHFT, Mid Yorkshire, Leeds, Bradford, Airedale would all be in that. Now
Brilliant.
that hasn't happened yet. We're in that procurement, in that development stage. We've procured the system. We know which system we want. We're in the development and rollout of that system at the moment. And Leeds is the next to go live in that. Bradford and Airedale and CHFT, and then ourselves are in early 2025.
That's really helpful. Thank you.
Councillor Firth?
I've just got a couple of questions. Forgive me, it's my first meeting, so if the questions seem a bit naive, you'll have to forgive me. You talk about more joined up services. From the patient's perspective, how will that affect them? Because the geographies of North Kirklees, Wakefield and Calderdale is huge.
Yeah.
So how will that affect a patient?
So our perspective on that is that care should be provided as close to home as possible, and where we can do that at an outpatient level, at a community level, that's what we want to do. I think it is imperative to view some of our services as being specialist and therefore requiring a centralisation in a sense, and the non-surgical oncology, which is non-surgical treatments for patients with cancer, so chemotherapy, radiology, that sort of thing. We've been through and are going through a consultation process at the moment. We've been through a design phase around that. As I say, that is being consulted upon, but that would have the inpatient side of non-surgical oncology based within Huddersfield. And therefore, those patients from the Wakefield district who required the services of a specialist oncologist would travel to Huddersfield for that. Now, again, within that model, what we are describing is clinicians who will be based in one area, but who will provide services out with that area. So there will be oncologists from Huddersfield who will be there in the Pinderfield site, and therefore if patients are admitted and don't require ongoing support, they'd be managed within the Pinderfield site with an oncologist giving advice and support. So that perspective around care as close to home as possible can play out in even some of the more specialist services, but sometimes, and it is important to reflect upon, sometimes the patient needs to be seen by the right person in the right place with the right equipment and with the right support. And in those instances, we would look for non-surgical oncology, we would look for that within those.
Supplementaries, yeah. Coming back, forgive me if this was finished some time ago, but you used to provide those services at the Boothroyd Centre in Dewsbury. Will that no longer happen?
So outpatient chemotherapy services will continue in Boothroyd in Dewsbury, and any palliative care support that is required for patients with a cancer diagnosis will continue in their local hospitals. It is really the specialist input from an oncologist, which if it can be given in an advisory way, that will be done and the patients will be kept in their local hospital. If it requires the ongoing treatment from an oncologist, then that would be delivered within Huddersfield. But that is the small part, that is really a small number of those patients who are admitted with oncology.
Thank you for that. Another one, if you don't mind. Where am I? I've written it down. Oh, of course. I welcome, and local people do welcome, the maternity services opening up at Dewsbury again. Have you got the stats to hand? I suppose you haven't. How popular is this unit? Have you been almost run off your feet by births at Dewsbury?
So we're pleased that we've been able to open the Bronte Birth Centre. I think it's a developing area. We're not run off our feet in terms of women who want to birth in that centre. It's a choice that women can make, but there are also safety considerations in a centre that is midwifery led. And I think women make those choices automatically. And there are also clinical guidelines. So there are some women who we wouldn't recommend were delivered through the Bronte Birth Centre. So there is a schedule, I think, for the maternity services to come back. At that stage, you'll get all the numbers. But what I would say to you is it's not as popular as you might think, because of some of those safety type concerns. And that's why we want. Well, so that could be part of the discussion. I think let's get the leadership of the maternity services here, and they can give you some of those answers. I can't give you the numbers; I haven't got them in my head. But there is a time at which you can scrutinise those. I think there are many reasons why someone might choose the Bronte Birth Centre or not.
Well, thank you very much. I look forward to that. I was involved in the discussions when you closed the Bronte some years ago. Can I just ask one final question on this? And it's not in your papers. Musculoskeletal unit. Have you got any plans to bring that on board again? Because the service is absolutely hopeless. Because I'm personally dealing with that. And it would be great if the Trust took that on board again.
So are you is that specifically Mid-Yorkshire, or is that...
The musculoskeletal itself is the basic capacity. You can navigate all of them. If you have got a problem, to never see it. And if you don't have any contact, you just dismiss it. You've got to start the whole process again. Sorry about that. I'll press the button. I think you've got to do it.
Just in relation to the musculoskeletal services that are provided, they are currently provided across Kirklees by Locala, and there is another provider, and forgive me, I can't remember the name of the other provider in North Kirklees. And there are small elements of the services that are provided by Mid Yorkshire Hospitals Trust and CHFT. That current model of service is currently under review by the ICB in moving forward. So potentially some of the issues that you're raising, the purpose of that and the way forward regarding the future provision of those services will address.
Thank goodness for that. And I press my button.
Thank you. Just regarding the maternity services, we did actually have an update on them at the JOSC. Was it about 6 weeks ago? They gave us a report of like numbers, various things, transfers. A couple of ladies had to be transferred, but when they actually looked at why they'd been transferred, that was the correct call. So hopefully it's still fairly new. As you rightly say, people are getting used to going to Pinderfields, and it's getting known that there is still the service there. Are there any further questions?
Yeah, sorry, I think a couple of mine have been already asked now, but just in relation to benefits you're already delivering. So you say you're delivering improved service resilience, e.g. on non-surgical for non-surgical cancer, where historically there have been workforce challenges. So how have you overcome? From what you're saying, is that what you're saying, that the new system actually has overcome those challenges?
Yes, that's right.
How is that? Sorry, if you could just explain.
I think because the number of non-surgical oncologists.
Sorry.
So the number of oncologists isn't enough to support the number of services that were in existence, and therefore, by working closely with Calderdale and Huddersfield, we've been able to centralise that resource in one area, in Huddersfield. with outreach to Mid-Yorkshire and to Pinderfields, and therefore the requirements are less for the number of oncologists.
Right.
And you may remember, or you may not, because it was a Wakefield type issue, but the number of oncologists at Wakefield, to run a rota 24 hours a day, 7 days a week, requires around about 6 oncologists. And we had, I think, 4 substantive and 2 locums, and then about 3 of them left, which left 1 substantive person, and then 1 of the locums left. And therefore you couldn't cover the whole service. And that's what we mean by resilience. You need to be confident it's going to be there if it's offered, and it can't be at the vagaries of 1 person leaving or 1 person being on sick or that sort of thing. So that prompted the review, and that prompted the work that led to a South sector model, which is Calderdale, Huddersfield and Mid-Yorkshire working together, but delivering the inpatient base out of Huddersfield,
Right.
which is more resilient.
Yeah. So is that actually does that actually mean that you're able to deal with more patients more quickly, more effective, well, more efficiently? Has it speeded up the process? Because I know there are waiting lists, various lengths.
So what we've done as part of the review as well is try to right size other parts of the service. So the chemotherapy suites, we've tried to look at how many chairs we need and how many advanced care practitioners we need, how many pharmacy consultants that we need, because we've gone for an alternative model, and we're able to right size that. So it's still in the process of being implemented. There's some consultation still continuing around that, so it hasn't resolved those issues yet, but we think it will be more resilient and therefore more able to respond to the needs of the population.
Thank you. I've just got another question in relation to the new pathology network. I just wondered if you could just explain, will the new network, will that give you more capacity? Will that increase your capacity to deal with diagnostic testing, basically? That's what I want to know.
Yeah, that's the purpose of that, is to increase capability and capacity, so that we can get diagnostics done more quickly. And diagnostics are key to getting the diagnosis and therefore the treatment pathway for the patient.
Thank you. Thanks very much. That's it. Thank you.
Councillor Bamforth.
Thank you, Chair. Just a quick one on digital integration. Is it compatible with any other trusts? For instance, if someone moves in from another trust and also out, how is it to get the records for these patients?
So certainly the Calderdale and Huddersfield electronic patient record is compatible with Bradford and Airedale, and if we get our business case approved, then we'll be compatible, and therefore you can see that much more of the population covered by a single system, with notes and records being transferable. Certainly on the specific item of chemo care, which is the non-surgical oncology system, we've agreed to buy 1 system for all of the organisations within West Yorkshire, and therefore that will be more compatible. And that's the direction of travel that I think we're on. More and more, as systems need replacing, I think we'll start to think about those systems from a West Yorkshire point of view. We will certainly think about them from a Calderdale and Huddersfield and Mid-Yorkshire perspective, but we'll also encourage the rest of West Yorkshire to come on board with that as well.
Thank you.
Councillor Firth.
We'll get fed up of it. On that issue, I'm amazed that there isn't a national system whereby, say, I moved from Scotland or went up Scotland, your computers wouldn't talk to my new trust. It's crazy that there isn't a national system where everybody can talk to one another and collaborate.
So there are, even with the plethora of systems that there are mechanisms. There is a spine of patients, so we know all patients, we know they're contactable through the administration systems, etc. But each organisation has the ability to procure its own system, and as I say, through collaboration we are working together to make sure that that's a consistent offer for West Yorkshire. But there has never been a national system in the way that you describe. And there's an awful lot of risk if there was, because if you have a national system and it doesn't work very well, it doesn't work very well for anybody. Pardon? Well, but systems they develop over time, don't they? They develop over time, and my sense is there's never been an appetite for a national system. There's an appetite for people to collaborate, for organisations to collaborate more, and I think that's what we're doing.
I just find it surprising.
Thank you. Are there any further questions? Okay. I'd like to thank you for coming today and for your report. Thank you.
Thank you.
Before we move on to item number 8, which is the mental health and wellbeing report, because some of the speakers were actually here, we'll just do another round of introductions. So my name's Jo Lawson, I'm chair of this committee and councillor for Crossland Moor and Neverton Ward.
Eric Firth, Dewsbury East.
Kim Taylor, Voluntary Co-op Tea.
Councillor Munro, Almondbury Ward.
Councillor Tim Bamford, Denbydale Ward.
Thank you. Sorry, we've also got Helen Clay, who's actually online as well.
Thank you, Chair. So what we'll do is we'll do a quick round of introductions, and we've got a colleague who's joined us on screen as well. And then I'll just introduce what we're going to talk through. You have got the full data pack and full information in your pack. We're going to take you through a shortened summary set of slides and then open it up for the discussion. So I'm Vicky Dutchburn, I'm Director of Operational Delivery and Performance for Kirklees ICB.
Afternoon, Michelle Cross, Service Director, Kirklees Council.
Hi, I'm Richard Parry here as the Strategic Director for Adults and Health at Kirklees Council.
Afternoon, Lucy Wearmouth, Head of Improving Population Health and Public Health.
Good afternoon, Paul Howitson, Transformation Manager at the Kirklees ICB.
Good afternoon, I'm Jen Mosley, the Programme Manager for Community Mental Health Transformation.
And on screen we've got Chris Lennox, who's... Are you there? She's disappeared.
Yeah.
Oh, go on, Chris.
Hello, everybody. Chris Lennox, Director of Services Mental Health for Social Partnership Trust.
I think we've got another colleague from the Trust, Paula.
Hi, I'm Paula Loftus, Quality and Governance Lead for Community Recovery Services for South West Yorkshire.
Okay, so you sent us a series of questions to help us pull together the pack that we've shared with you. What we're going to go through is a summarised version of that information. So what we will be covering briefly is the availability of mental health services and mental health support across Kirklees, how residents of Kirklees can access that support, how partnership working supports us in delivery of those services. And when we talk partnership working, it's not just the ICB, the Council and South West Yorkshire Mental Health Trust. We will talk about our community services, our voluntary sector services as well within that. We'll be talking about the community offer because the aim of everything we do is to try and deliver services as care to the individual's own home and out of hospital if we can. So we only use hospitals for those really acutely unwell individuals for the shortest length of time. Give you a brief summary of what we call talking therapies, so that's our access to psychological therapy type services. Crisis services, so you can sort of see both extremes of the services that we offer, and then also some of the gaps that we've identified and that we're going to be dealing with over the next few months and years. So different people will explain elements from these slides for you, but we're now on slide 4, sorry, and I'll hand over to Paul.
Can we move the slides on, please? And again, that's it. Thank you. So this is providing reassurance that there's a pyramid of mental health support for different levels of need. So from the base of the pyramid, you've got universal services working up to tertiary level services, which are very specialist national and regional services. And then on the left-hand side, there's a range of more local services that are aimed at crisis or people that might be experiencing crisis in different places where they present.
If you could move the slide on, please. Thank you. So these are ways you can access your mental health support and specialist services. If I could bring your attention to the IFR, stands for Individual Funding Request.
Chris, the next one's for Swift. Do you want me to do this or? Okay, if you move on to the next slide. What we've got on the next slide is just some of the access standards that within Swift, if you are referred into South West Yorkshire Mental Health Trust, the access to their services. So all routine access is within 14 days. And performance is currently averaging at 81% of all those referrals that are being seen. And then for ongoing treatment, once you've had that assessment, it's within 6 weeks of the pathway. So again, 89% of people who are assessed are accessing that service, are accessing those standards. Swift have got an ongoing quality improvement approach. So within all their services, they work with quality leads to look at the ongoing information that they're getting from their services. So they are very data-led to improve the services and the pathways that they deliver. And they use that insight to not only improve the waiting times and the access standards, but also the interventions that they're offering to individuals. And what they're also doing is looking at further development of what we call waiting well. So while people are actually waiting to start an intervention, if you've been referred in, you may be signposted to other services that we have while you're waiting for a specialist clinician to be able to fulfil an intervention. They're using all that work and doing all that work on an ongoing basis, and they do involve the commissioners in that work and share that work with us so that we can help facilitate some of that, working back out into our community services and our primary care settings. If we move on to the next slide, please, which is about working together with our voluntary sector communities.
So these just give some examples of services that may be joint funded or funded by either the local authority or health or a bit of both, and draw your attention there to obviously moving towards digital solutions like the Brain in Hand app. Then the next slide, please.
Thank you. So this slide just draws your attention to some examples of support available in the community. Our mental health social prescribers based in primary care networks often signpost to these services and support people to attend.
And then just towards the end of that, there's an acronym, the IMHA, is the Independent Mental Health Advocacy or Advocate Service. And then the last bit is around the Advocacy Hub that's run, that's commissioned by the local authority. Next slide, please. So just on this slide, it's about accessing the support that people need and various ways of doing it through online, through signposting, and whether there are any gaps within which partners encounter in the support you're able to give. And where it says increased demand for befriending, this can be by attending a community group or activity and or the support to do it. So it's about finding the right level of service for people for that.
And if you can move on to the next slide. So the next slide, I'm really conscious that working with our voluntary community sectors is quite an emotive subject. It's also been picked up at West Yorkshire level about how we support the voluntary and community sectors and how we make that sustainable. That it's one of those sectors where they tend to be on annual contracts or getting grants and don't know where they are I suppose, year to year. So what I've just tried to do on this slide is just show you the approach that we're taking across Kirklees to evidence that our BCS partners are integral to all the service delivery that we do. And we've taken that right through our strategic planning, right through to delivery, so that's reflected in our health and care plan, our ways of working, so we make sure we've got full representation on all our formal committees and statutory committees and the subgroups that we have under those, that we have across Kirklees an investment strategy with 7 agreed actions, and this is in line with the West Yorkshire strategy as well. So it's what we're doing to implement that, and we work very closely with the third sector leaders to build those relationships and develop that across Kirklees. We also have the inclusive communities framework for Kirklees, which as a collective system we're signed up to. And what that helps us do is make sure that we're asking those questions all the time, that people are involved from the very beginning. Are those providers best placed to deliver what our communities need? How do we harness what is already in communities and further develop that, rather than always starting from ground zero, so to speak? We're working with the third sector specifically around our engagement and getting the views of our public. So we have what we call the community champions, and they're people that we've helped to develop so that they can hold those meaningful conversations with our communities, but bring that then back into our statutory organisations so that we use that as part of all our planning processes. Within this, what we are also doing is trying to move away from just giving grants on an annual basis. So there are a number of services that, as they get reviewed, if we collectively recognise that they're delivering really meaningful services for us, they're doing what we need them and want them to do, we're looking at how we can get them on longer term contracts and built into our whole infrastructure, so how we can use our Better Care Fund better to support some of these community organisations as well. And within mental health, for a number of years now, we have jointly with the local authority procured the voluntary sector to deliver services for us, and we've given minimum of 3-year contracts with abilities to extend. So we've been building in that resilience as we've moved forward. If we move to the next.
Thanks, Vicky. Excuse me. So the primary and community ambition, we're in year 2 of a 3-year programme. It's split into 2 elements. It's new roles in primary care network, so that's at your GP practice, and it's also around swift bringing existing services into the community. It's a real example of partnership working and successful partnership working, and it's a complex programme of work. If you could move to the next slide, please. So the model that we've shared demonstrates the roles that are already in place that we've successfully implemented. They are in green, and the blue titles are ones that we're working on for phase 2. So we're in progress with mobilising. And if you could move to the next slide, please.
So I'm going to talk a little bit about the community offer within SWIFT. So the community services provide assessment, care management and interventions, ensuring face-to-face contacts wherever it's clinically indicated or whether there's a choice from an individual. The work's ongoing to adopt a collaborative approach to the care planning, building the community resilience and offering care at home with a real focus around care at home. This includes the robust gatekeeping, trauma-informed care and effective intensive home treatment. So the teams are working closely with acute pathways to ensure purposeful admissions and timely returns to the community. And we continue to work in collaboration with our places to implement the community mental health transformation. We're currently looking at the service offer to optimise opportunities for innovation, effectiveness and partnership, working to achieve the best model possible for the service users and carers. You move on to the next slide, please. So I guess some of the challenges that we've faced, and this is something we'll talk a little bit about within Talking Therapies, the slide around Talking Therapies, is the workforce challenges. So we're currently experiencing higher levels of vacancies within our community teams, specifically around qualified practitioners. Now, to counteract that, we have some plans in place, but we're also aware that this is a national picture as well. It's not specific to Kirklees. We're being proactive and innovative in our approaches to recruitment. So, for example, the introduction of the trainee nurse associate roles in Kirklees following new investment and use of additional staff and sessions for the single point of access assessment slots. We're very mindful of the increased demand for services as well. We've noted pressures within our spas. And at the moment, our spa is prioritising risk screening for all referrals to ensure any urgent demand is met within 24 hours. If you move on to the next slide, please. So you'll hear me referring to talking therapies and IAPT interchangeably. I guess that talking therapies is a national programme, and it was recently rebranded from IAPT to talking therapies, which we think is a positive change. Talking therapies have a number of access targets, or a few access targets around access to assessment as well as access to treatment. So currently within Kirklees Talking Therapies, we have 100% of people who are referred in will wait less than 6 weeks for their first assessment, which is over the national wait time target of 75%. Within Talking Therapies, there are two main treatment pathways. So we have a low intensity pathway based on cognitive behavioural therapy and a high intensity pathway. Most people referred into the service will start at the low intensity pathway and then progress to the high intensity pathway. The low intensity pathway includes offers of guided self-help, which is normally delivered by a psychological wellbeing practitioner, computerised CBT, which is our digital offer, a programme called Silver Cloud, which is something that people can work through at their leisure, facilitated by a PWP. And then we have our psychoeducational courses. So we have our stress control course, and we also have our low mood course as well, which are really popular. In our high intensity offer, we offer cognitive behavioural psychotherapy, counselling for depression or CFD, eye movement desensitisation, couples therapy for depression, and interpersonal therapy. So currently, as it stands at the moment, we're really pleased to say that we have no wait times for the low intensity offer, with people accessing treatment immediately following the point of assessment. Can you move on to the next slide, please? Our wait times for high intensity are grouped together, and the target that we work towards with the high intensity is, or with treatment in general, is that people should access treatment within 90 days. 90% of people should access treatment within 90 days of their assessment. At the moment, our high intensity treatment sits at just over 70%. So people accessing high intensity therapists are waiting longer due to the workforce pressures, and this is similar to what we mentioned earlier in terms of the community services. We're having difficulties in recruiting to qualified therapist position, and this is a national challenge and not specific or isolated to Kirklees. But we're also looking at ways that we can counteract that. So, for example, recruiting to trainee positions and trying to grow our own workforce, reaching out to the local community, or workforce that's reflective of the local community. Some people will also wait longer because they have specific choices. So, for example, a particular location or time of day. I guess the assurance that we can provide is that everybody waiting for therapy has had an assessment of their risk. They should have contact numbers and a staying safe plan, and they're offered psychoeducational material while they wait to access therapy. Next slide, please.
I think that's the home-based treatment, and this is really about the crisis pathways that we have that obviously complement both our acute and our community services. And we've got home-based treatment and mental health liaison, and you could say they work with most vulnerable service users, and those most at risk at times of crisis. And obviously the emphasis very much is keeping people out of hospital and working with them as close to home as possible. But home-based treatment focus on the needs of people who would otherwise be in hospital. So mental health liaison work in the acute hospitals and offer a range of assessments and interventions. And they work 24 hours a day as well. And their performance target is to see people within 1 hour of referral, and they meet that performance target in nearly all cases. Home-based treatment similarly work 24/7, and they have the gatekeeping responsibility for all inpatient beds. So an assessment by home-based treatment is an essential requirement for admission to hospital. They do work in partnership with local authority approved mental health professional colleagues in making decisions around admissions under the Mental Health Act, but they facilitate patient flow and bed management during those times as well. So home-based treatment meet their performance requirements. They've not been without the workforce challenges too, which we've already alluded to. And Kirklees has been challenged with recruitment, but there have been some improvements there. But given that we do meet our performance requirements of 4 hours for assessment of all those crisis referrals, and we do offer a 72-hour follow-up of people who have been in hospital and then need to be seen in the community when they come out. So it's a busy team, home-based treatment, average over 3 years, 106 referrals a month, and an average of 615 contacts a month as well. And very positively, Kirklees have had additional investment, which has led to the appointment of a second consultant psychiatrist to the team, which has really strengthened the clinical oversight and ability to work with people. So that's a very positive development for us. And I think the next slide is Paul, and this really provides the context, doesn't it, that we deliver crisis services in, which has strengthened again considerably in Kirklees in recent times. So Paul, it's you now, I think.
Yeah, thank you, Chris. So this page is an example of better partnership working, and the investment's gone into different services and different service lines. So, for example, the mental health crisis support line is provided by an independent sector provider or third sector provider for Kirklees, Calderdale, Leeds and Wakefield, as well as Barnsley. And these additional investments or additional resources came from the long-term plan 5-year forward view, or from the emergency funds that were released through COVID. Drawing your attention to bullet point 5, so the mental health emergency department steering groups. Oh, can we go back a bit? Thank you. Move on one, sorry. Yeah. Thank you, Vicky. So bullet point 5 about the mental health emergency department steering groups covering CHFT and Mid Yorkshire teaching hospitals. These two steering groups help to smooth out the pathways. So when someone presents with a mental health issue at an emergency department, it's then about focusing and targeting where they need to be rather than the emergency department. So it's working in practice with different agencies to join up and make those pathways a wee bit more seamless, so that they're transferred to the right setting for the right level of care that they need. And then obviously working with West Yorkshire Police and the mental health triage and control that goes into there, the section 136 of the Mental Health Act suites for police detention, where somebody's detained under the Mental Health Act, they either go to the Dales at Calderdale Royal or to Fieldhead Hospital in Wakefield, the mental health hospital in Wakefield. And then just finally to draw your attention to the last 2 bullet points, these that are badged alternatives to crisis, these are both contracts with the voluntary sector. The Crisis House Rest Stop service, and Rest Stop stands for Respite, Emergency Support and Time Away, is provided by Community Links at Trinity Street in Batley. And this is a service that is an alternative to being admitted to a mental health hospital, but someone needs some time away from home or the place that they call home with a supportive workforce around them. And then the other alternative to crisis is the Crisis Cafe, now called the Here For You service, used to be called the Wellbeing Crisis Cafe, operated by Touchstone, which operates currently 6 till midnight, where people can either get telephone support or can actually have in-person support with, again, supportive and well-trained staff around them. Then if we move on to the next slide, please. So I think there was a question around other sectors that we are involved with, and obviously from there, there's things like housing and accommodation services. So access to stable, good quality housing is really a key determinant for good mental health. And then for people living on boundaries, obviously, they choose and go to access other services. So people in South Huddersfield, for example, Sisset, Clayton West, may choose to access services in Barnsley. And then we said about individual funding requests, and that's actually spelt out on there as well. So yeah. Okay. Next one's Lucy, I think.
Afternoon. So just a reminder, I'm Lucy. I work in public health. Next slide, please. Thank you. So I'm going to talk to you about suicide prevention, and I think the first really important thing to say on this slide is that actually suicide prevention runs through everything which the team have already described today. So the pyramid that Paul showed at the beginning, that pyramid of mental health support, suicide prevention should run through all of that. What I'm going to talk about today is specific work which is happening around suicide. So just to talk you through a few of the key points here. Reducing suicide rates is one of the 10 West Yorkshire ICB ambitions, so it is something which is incredibly important nationally and regionally as well as in Kirklees as well. A really important piece of work which we've just finished is the suicide audit. So if you've not heard of one of those before, we've been working with Calderdale and Bradford and Kirklees with the coroner to examine all of the deaths by suicide across the region between 2019 and 21. And what this has enabled us to do is to understand themes which are running through those suicides. So there is a suicide audit which is available online, which you can read, but it breaks it down in terms of age, gender, other risk factors. So it's really important that we understand those intricacies of suicide, because obviously it's incredibly complex. The other thing to mention is that, which isn't on the slide, is that there is a suicide prevention action group as well within Kirklees. So there are a number of colleagues from a range of organisations who sit on that suicide prevention action group, and falling out from the audit is an action plan as well. Other things just to highlight to you, there is a new service which has been provided by Stepping Stones, which has been commissioned across Calderdale, Kirklees and Wakefield. So this is for people who present at A&E who have self-harmed. There is a strong relationship between self-harm and suicide, and what Stepping Stones have been commissioned to do is that when someone presents at A&E or is admitted because of self-harm, they are then referred to Stepping Stones to have additional support. So obviously that's an incredibly important new service which has been in place just since July, I think. We had self-harm as well. There's a lot of stigma around self-harm, and part of the work that we and colleagues across the system are trying to do is to help to reduce that stigma around self-harm and also enable people to talk about it as well. So we had a workshop in July with stakeholders and system partners to raise awareness of self-harm and to support people how to respond, because it can be difficult conversations to have. We have a commissioned family postvention worker for families and young people who are bereaved of suicide in Kirklees. And then we also commissioned suicide prevention training across Kirklees. So that's about how to have conversations, how to notice when someone might be kind of behaving differently to what you're used to seeing, the right questions to ask, how to support people, where to signpost people to. And then finally, working within the council but also across the system, it's really important that we are all trauma informed and that we are a trauma informed system. A lot of evidence shows that our more vulnerable communities are much more likely to have experienced trauma within their lives, and it's really important that people that workforce and people who are working on the front line are kind of understand that trauma and respond appropriately to that. And that's it from me for this slide.
Could we have the next slide, please? Thank you. So, as part of the question pack, we were asked what were the gaps with mental health services. The first one that we identified was the need for a service for those who don't quite meet the criteria of our specialist service in Leeds. As part of phase 2 of the Mental Health Community Transformation Programme, we are commissioning a disordered eating digital self-help offer, which will prevent people from reaching crisis and offer early access and psychological intervention.
And the second one on there is regarding transitions. So this is a key theme of the Kirklees Mental Health Alliance, looking at transitions between age boundaries, not just children to adults, which is mentioned there, but also for working age adults to older adults, but particularly for children to adult services and those aged 18 to 25. And some of the work that's underway already, some is undergoing at West Yorkshire level and some is at place-based. And there is the stuff to look at digital solutions, pathway redesign, and because children and young people are more accessible to technology, that they respond better or well to those sort of modalities. And then we've got obviously the Starting Well programme and Kirklees Keep in Mind as well.
If we move on to the next slide, please. We've already mentioned this one under the South West Yorkshire Mental Health information, but access and demand to services has grown phenomenally since COVID. So not only have we been trying to get things back onto an even keel post-COVID, it's also working with the increased demand that we're seeing. Some of this is national, so it's not unique to Kirklees, which is about the shortage of suitably qualified staff. Specifically clinical psychology therapists that we're seeing, and also the fact that from NHS England it's quite prescriptive on some of the workforce that we've got to recruit, which is fine when the national guidance comes out, but actually it can take 3, 5 and 7 years to do the full training of these people, so you've got to build it into those future plans. It's not an immediate fix. And within that, it's then how we incorporate those into our existing services and where we place them within the models that we've got. So we are looking at bringing more qualified staff into our primary care networks and community networks to do that front end and try and get people as early as possible. If we move on to the last slide, the final 2 gaps that we've identified here are, one is about public awareness. So the public understanding what services we do have and what we can actually deliver, but also about what the public can do to facilitate self-help, look after themselves and access services elsewhere. That this isn't always about coming into hospital and getting services, so it's about how we work collectively with our community and those community assets to promote that self-help. And then the final one is about, and we picked it up on the earlier session with the Acute Trust, is about the data that we've got available to us and how we integrate some of the systems to facilitate better care for individuals, the sharing of information, which is easier said than done for numerous reasons. Not only that not everybody's on the same system, but actually because you're talking about multiple partners and they're all from different statutory organisations, or they are independent providers, so GPs are actually independent of the NHS. You've got to get all those people to sign up to data sharing agreements to protect the information that's going to flow between providers and also on how that is used. So we do have systems, work streams established across our system to start addressing these and working with it, but again, they're not quick fixes. So that's the end of the presentation, to open it up for any questions. And obviously your data pack had more in it.
Thank you for the presentation and also the very comprehensive report and update. One thing I actually really liked was the fact that you did mini case studies regarding over the rest house, because sometimes you can hear all of this thing, but you need to know, does it really work for people? And having sort of lived experience, somebody giving their experience of a system, it can really sort of help. So I really actually quite like that. You were talking about going on about the triage of routine referrals. You stated that there's some risk of it being delayed. On average, how long is a routine referral waiting to actually be triaged?
Let me bring Chris in.
Yeah. Our target is to see people within 14 days for assessment, and largely nearly 90% of people are seen within 14 days.
Thank you. And going on to the mental health social providers, is that one per PCN patch or is that one per GP?
Is that the social prescribers?
Yes.
Yeah, Jen.
Thank you. So we have mental health social prescribers that cover each PCN in Kirklees, but we also have generic social prescribers, so the team cover all 9 PCNs. They are working across all practices, but each one has an equal distribution as to how many clinics they have and how many people they see.
Thank you. I'll open it up to questions from the panel. Councillor Firth.
Thank you. I've been scribbling away quite medley here. First of all, by the way, I have some questions, but they're not a criticism of you. I think the service you provide is absolutely fantastic. Though I must admit, looking at them and hearing the presentation, it almost looks like stretched to the limit, almost in crisis. But can I ask, first of all, I saw a bullet point, and it wasn't in your presentation, about life expectation of it's 15 years lower in certain areas for people with mental health. How do we address that? Is it lifestyle, or how do you intervene to make that better?
So yes, it's a nationally recognised difference in life expectancy. What we have within Kirklees is we have a range of what we call health inequality programmes to try and address those inequalities and where those gaps are. We annually map the themes so that we can adjust the programme accordingly. Some of the programmes that we have in place include workers between South West Yorkshire Mental Health Trust and primary care who do annual health checks on people who are known to be people with mental health, mental illness issues, so that we make sure that they get their annual health checks. We signpost them where appropriate to other services, so we can try and facilitate people getting the right quality care at the right time, and we're promoting that actively. Again, we use our community champions, so they do some really targeted work, again around specific themes. So one of the areas we've identified from last year that we've been working on, well, 2 areas. One was about people with mental illness and diabetes, and they weren't as compliant with their medication, the follow-ups. So we've done some targeted work to try and improve that with individuals, done education sessions, but also the workers have taken them to clinic appointments where people were reluctant to attend other hospital clinic appointments. And one of the other areas that we've worked on is some of the cancer screening programmes. So they've done work to support people to understand those cancer screening programmes, like the bowel cancer, which isn't unique to people with mental health problems, but we've done targeted work, breast screening for people, so they understand how to check themselves, but then again, getting them into clinics and sessions if that's what's required for them. So it's doing more targeted, I won't say hand-holding, but it is really support to those people to try and make sure we're targeting it. We recognise we're not going to eradicate health inequalities, but what we're trying to do is close the gap all the time. And annually there is an audit of deaths of patients, if they're known patients, so that we can see what are the themes that are coming out, so we can adjust that programme on an annual basis. So we did a lot of work straight after COVID because there was a lot of respiratory issues and conditions, so we did a lot of targeted work for people with respiratory conditions, COPD, chronic obstructive airways disease. We have an ongoing campaign around asthma, so we make sure that it's targeted as well, to try and promote it equitably across as well for people.
Thank you. My next question, there was a slide on gaps, but yeah, for me, there's a gap you didn't address, older people and loneliness. How do you address that gap?
So again, I mean, there might be somebody else wants to come in on this one. So loneliness is a specific theme for Kirklees under our public health programmes. So we've got that specifically. It's not a unique mental health problem, but what we do is we make sure we target within mental health to support that the universal piece of work we're doing around loneliness, promoting it across well, not promoting loneliness, but promoting people across our communities about how they engage with our populations, how we use our social prescribers to do signposting, so that hopefully people don't get sucked into the mental health system because of loneliness, that we find those other ways of coping and managing within our general society to support the population.
No, I'm here again, Chair. I'm sure after COVID, that will have an impact on older people's mental health. My next comment, question, is throughout this report, there's a thread about recruitment, though it doesn't mention retention, by the way. You describe it takes 7 years to get people up to standard. But obviously, that's not universal in the different sections of the services you provide. Is recruitment a problem, not just for the top jobs, shall we describe it as that, but for the ordinary jobs, because they're not ordinary, they're extraordinary, but you know where I'm coming from.
Recruitment is a recognised problem nationally, not just for mental health, but for all health and care professions, yeah, regardless. What we do in Kirklees as a system is we work collectively as a group of organisations and systems to look at how we are recruiting, where we are recruiting, can we be more creative? We have really active relationships with the university, with the college and with the schools, not only as individual organisations going out and promoting, but as a collective system. And the colleges come in and talk to us collectively. So what we're always doing is looking at opportunities we've got for work experience to try and encourage people to come and test us out, see what they think, but also apprenticeship schemes. So we're actively working with that, not only for people, the young people coming through who are looking for jobs, but for some existing people who are made redundant to start coming into the sectors as well. Other areas that we're actively working on collectively is with our, I'm going to say, is our care sector, so our care homes, and the Kirker infrastructure around what we can do around payroll, training, and things as well. I don't know if you want to talk about that.
Yeah, thanks, Vicky. And I think Vicky's answered the majority of the questions, but we do have, like Vicky said, a really strong relationship with the university. We have an intake of social workers every year, but we also offer social work apprenticeships across the council, and that's not just for young people, that's for existing staff. Who may have a keen interest in social work. So there's a whole raft of things that are on offer for people in Kirklees, across the council and across the system. And like Vicky says, we do work closely with the colleges, we offer work placements, and like I said, the new health and social care campus that's been built, that will provide a massive opportunity for Kirklees, because that will be nurses, general nurses, mental health nurses, learning disability nurses, OTs will be part of that training offer. So I think once that campus is open, that provides us a great opportunity. And I think, like Vicky says, as a system partner, we are working closely with the university to see what those opportunities will afford us in Kirklees. Retention is always an issue. Unfortunately, because people do always, sometimes jump over the fence because pay is different. We don't have one spinal column across NHS or the council, so sometimes we do lose people for pay, not always reward, because we have seen that people do return to Kirklees because they do like the flexibility of Kirklees. We've seen that across all disciplines, I have to say, over recent times, and more so post-COVID. I think from a professional point of view, our approved mental health professionals, it's the first time that we are fully staffed, and I think that is unique to Kirklees. That is a real struggle, but we are really proud of the work that we've done in terms of working with our approved mental health professionals, so that is something to really celebrate. And that also means that we are meeting our statutory duties and we will have no breaches across the system, which again is something to be really proud of. So lots of work to do, but like I said, it's a national issue, retention, because pay is always difficult.
I think the other thing that it's worth us saying as well is that what we're further exploring now is how we as professionals can go out and reach into our voluntary sector communities. So we're looking very closely at further development of our volunteering schemes, so that what we can do is where we've got a skill set, so for example business case writing as an example, we might be able to go into a third sector organisation and help them write business cases so that they can attract funding from different places. But what that's also doing is then sharing the skills and the knowledge, which means if people do want to move around, they're starting to be able to evidence transferable skills because we're passing those skills on. And I think the other thing around retention that's worth us noting is that whilst we never want to lose staff, whether it's for pay or whatever, one of the things that we do try to promote is if people move within Kirklees, we're keeping the skill set and the assets within Kirklees. So if they're moving across our organisations, it's not a loss, it's that we're sharing.
Thank you for that explanation, very good. Can I ask one more question, Chair? This is all new to me, as I said, and what you described is excellent. But most of my colleagues, councillors, will be clueless, as I was. Would it be possible for you to provide, I don't want you to do it without Kirklees councillors, with just a little card, needn't be like that, with contact numbers, so we can actually come back to you or make referrals for people that need help?
We can update it. Annually we update I forgot what we actually call the Z card.
On the computer, a card.
Yeah, no, it's called the Z card. I think we mentioned it somewhere, and we tend to update it roughly about October, November time. And the reason we do it that time, which sounds a bit odd, is because it then supports us going into one of the most pressured times of the year when we're going into winter. So we make sure it's updated with all our contacts and our providers, so that we can get it into GP practices, we can get it into A&E departments, and people can start giving it out. So yes, we'll make sure that some come direct to you as well.
Thank you.
Thank you. Is there any other questions?
Thank you, Chair. I just wanted to ask a question, just going back to page 31 on ambition. The ambition was to embed mental health services into primary care networks, but they look like there have been some delays. So I just wonder if you could explain what the delays have been, please, and once it's all fully embedded, how it will improve and help mental health services as a whole. Thank you. Okay, so I don't actually think there's been delays as such. It's been a 3-year plus programme. So it was never intended it would all be completed within 1 year. There will have been, I'm going to contradict myself slightly, because there's been slight delays on what we set as a recruitment. So we have done the recruitment, but then due to people giving the notice, doing the training, it's elongated it. But we have been doing it, and we've not delayed the programme, it's been moving forward. And where we identified that there might be some delays with one workforce because we couldn't recruit, what we have done is, I'm going to say we flipped it. So we looked at what was due this year and we brought some things forward, so it gave us a bit longer to be able to recruit in. But I'll let Jen come in and give any additional information.
Thank you. Yes, I might take a moment to brag a little, but I don't know if it's out of taste, but our original model that was designed is actually much more forward than in other areas, and actually a lot of areas have scrapped their model and they're actually going with ours now. I know that sounds really big-headed, but I'm so proud of our model. So there is no delay. As I said, the roles that are in blue are phase 2, and they're in addition that we had funding left over, so we thought, how could we really utilise this and bump up our model for each PCN? And the benefits are outstanding. If we could recruit more, if we had the budget, then I know we would. But primary care feedback that this is freeing up GP appointments for them to deal with issues that they should be dealing with. Patients are seeing people who are experienced in mental health rather than seeing the GP and then going to mental health. It's immediate. You could phone your practice and ask to be booked in with an advanced clinical practitioner, and you know you're going to be seen by an experienced professional, and then they can signpost you either into secondary care services if they feel that's appropriate, or you can bounce back down to social prescribers. So I know one of the questions was, sorry, my heartbeat's going. One of the questions was around, loneliness for older people. A great example of the model is Tolson Museum on a Monday, where people come together. At Christmas time, they make wreaths, they do yoga, they play drums. It's that kind of lower level of support that's needed as well. And we have the same in North Kirklees at Oakwell Hall, where they do burn off your biscuits, which I need. So you go on a Monday afternoon, have some biscuits, and then walk around Oakwell Hall. It's getting out and being with people. It's these things that you can't capture necessarily in a data pack, but they really do have a positive impact. And yeah, primary care, as I said, saying these are really freeing up our appointments. The physical health and wellness team are really adding value. They're passionate, and as Vicky said, they are addressing physical health elements that should stop 15 years being knocked off your life expectancy.
That's amazing news, and I'm really pleased that it's working. So I'm glad I asked that question. So I've just got one other question. This is regarding talking therapies, and I have to say I think this is an amazing service. However, I've just got a question around their capacity currently to deal adequately with every case that they're dealing, that they're coming across that's been referred to them. Thank you. How are they? How they actually? Are you satisfied that they actually have the capacity and that they're dealing with things appropriately? Thank you.
Yeah. Well, I'll let Chris come in first about the talking therapist bit, and then I'll answer your commissioning question at the end.
I think I'll ask Paula, who's our quality and governance lead for that area, to provide you with that input. Thanks, Paula.
Yeah, thanks for the question, and I think it's a really interesting question. We do receive quite a significant amount of referrals coming through our talking therapies. I guess the good thing is that everybody that's referred into the service will get access within 6 weeks, so 100% of referrals. I guess one of the good things about talking therapies being based in Swift is that we have really good pathways and links with secondary care services, so we can take referrals to our colleagues in secondary care, and we can step up if needed, or we can also take through the single point of access if risk levels indicate a more urgent response. So that's probably one of the benefits. In terms of access to treatments, low intensity, there isn't a way to access low intensity therapy, which would suggest that we have a really good, robust workforce at low intensity, and people can access treatment as quick as possible, really just after the point of assessment. There are some slight delays in accessing high intensity therapy, but this is an improving picture, and we know that some of the challenges we're faced with recruitment are that we're targeting and working through those issues. So I hope that kind of summarises and answers that question for you.
Thank you very much. Thanks.
If we can get Helen, who's actually online. Helen, sorry, we can't hear you. Are you actually on mute? No, we still can't hear you, unfortunately.
No. Chair, if she'd like to send a question in by email, we'll respond.
Helen, they have suggested that if you wanted to email your question in, they would respond to it. Okay, thank you. Kim, did you have a question?
Yeah, one was a question, one was a comment. In terms of the staffing for the PCN models, the ACP Advanced Community Practitioner, is that just one that goes round each PCN? What kind of numbers do you have? I guess what I'm at is like, are patients going to be able to access experts like this, bearing in mind, the level of poor mental health at the moment, and how do you know you've got the numbers right? Is it something that's going to be consistently evaluated? I mean, it sounds from what you described, it's great in terms of freeing up GPs appointments.
Before Jen comes in and answers the question about what we've currently got, what I do need to say is that the budget that was allocated for doing this, so the new money, was a set amount of money that came from central government.
Right.
So what we've done in Kirklees is we developed the model, we co-produced the model about what was the best model we could with the money that was going to be available. What we do annually, even more than annually, if we've got recruitment issues, or if we've got people leaving, or a post hasn't worked, it gets constantly reviewed when that money becomes re-available. So some of the roles have been tweaked. Tweaked, that sounds weird, doesn't it? Have been tweaked as we've moved. So, for example, we started with a model that we all believed was a good fit, but some of those roles have evolved. The other thing that I will say is, even though there was a defined pot of money that came centrally, as an ICB, we have contributed more to that. So there was some money that was with primary care themselves. It was called the R's roles. But what we've done is we've made that sustainable, and we've paid for that. We picked up that funding because it was only non-recurrent within primary care. And when we evidenced the value of the posts, we've done other things to make that money recurrent.
Oh, that's
so we do adjust it, but it was a fixed amount of money to start the development of the model. But I'll let Jen come in about the numbers.
Thanks, Vicky. Yes, so each PCN has an ACP as part of the hub. At the moment, capacity is a bit limited because they're studying for their masters, which means 1 day a week they're at university, 1 day a week they're in practice offering a mental health clinic. The other day that they're in practice, they're learning around the physical health elements to the course. And 1 day they're in Swift with the psychiatric team. However, they're nearly qualified now, so they're already qualified in prescribing, which is fantastic, and they've got 1 more year, and then after that the capacity will shift completely because they'll be in primary care all the time. So yeah, it's something that is a fantastic service. Like I said, that they really are making a big impact in primary care, because at the end of it they'll be able to offer that physical health care as well as the mental health experience. Does that answer your question?
Yeah, it does, thank you. Obviously, it's a new role, isn't it? It's a developing role, so it's great. And I guess my last point, really, it was a comment. It's not a criticism at all. It's just a comment about the other services that are available in terms of the voluntary sector. I come from an NHS background, but half of them I haven't heard of. So it was just about, it might be me, but, you know, I go to my local library, I volunteer a bit in the food bank, and I do bits and pieces, even within a hospital setting. I've never seen a lot of information. I've never seen the Z card. A lot of these organisations that you list here, I'm not aware of. It might be me, not because I'm not cited on them, but it was just a comment really, about making aware to the wider public the support that might be available.
We'll take that as an action. We'll take that in through the Mental Health Alliance. So there's a Mental Health Alliance where all our statutory and our voluntary sector have representation, service users and carers. And I propose that we take that in there and pose it as an action for how we get wider communication.
And even like in the ED, in Dewsbury District Hospital, there's a lot of mental health that comes in. First point of contact, never seen anything.
Yeah,
again,
we'll pick that back up.
It's just a comment.
Yeah. We'll pick that up, and then hopefully next time you come,
Thank you.
You might be able to say you've been somewhere and seen some information.
Thank you.
Thank you. Helen's actually put her questions in the chat box. One of the questions that she was actually asking was, what was the wait period for the high intensity therapies and also the ADHD diagnosis?
So, I'm going to let Chris or Paula answer the question about the high intensity workers. Regarding ADHD, I'm going to answer that as a direct question because you could broaden this out to any neurodiversity and ASD. Currently in Kirklees, for adult ADHD, it's an 18-week pathway. So from the point of somebody being referred by their GP into the service, they will get an assessment and start a treatment pathway within 18 weeks. So that's for adults. We do know it's longer for children, but we do have pathways, and we are working on getting that down for children. Currently, Kirklees is one of the better areas in West Yorkshire, even for children. We're just over a 12 week, I was going to say, God forbid, 12 month, where it's between 12 months and 18 months for children to get their assessments. But we are working on that, both at a West Yorkshire level and a Kirklees level. But just so that you're aware, what I will say is neurodiversity wasn't included in the pack at all. And one of the discussions that we've been having as a senior leadership team as Kirklees through the Health and Care Partnership Committee is doing a deep dive into neurodiversity and bringing something in. I think, don't quote me, but I think they've said about January time, and we're going to bring a pack of information about what the position is in Kirklees, the work that we've been doing, alongside the work that is being done as a West Yorkshire, so that people can see the two together, because we're trying to marry the two together, because it is again, it's a national problem, is neurodiversity diagnosis. But I'll let Paula come in for the talking bits.
For the high intensity therapy, on average, it's less than 3 months. So 70% of people who are referred after the point of assessment would access high intensity support within 3 months.
Thank you.
I was just going to say, in terms of our dementia pathways, I haven't got the data to hand about the any specific weights for diagnosis, but it is quite a complicated process because it's partnered in primary care and in our services in terms of people begin their diagnosis journey and there are various tests and screenings required, and then they come in for different appointments and they're seen by one professional, and then they might be seen by a diagnostician. So it is fair to say that the demand for diagnosis of dementia is increasing, and we are struggling with that in terms of capacity across the system. But the service is very comprehensive, and we offer support to those people whilst they're waiting for a full diagnosis as well. So I do think it's an area of concern, and we have improved it we have included it in our Improving Access to Care priority programme as well, and we're looking at some drill downs of data and cross-referencing that with inequalities data that we have as well. So yes, we do have a very comprehensive service for people with requiring a diagnosis of dementia, but it is under pressure.
Thank you for seeing that actually in the chat window. That was going to be the next question I was going to ask. Helen has also put in there, it was mentioned that access to high intensity treatment and support is affected by people's choices. She just wondered if some of these were possibly related to the nature of their trauma, is the preference for a gender, or the inability to actually travel to treatment centres.
Paula, have you got anything that you can share?
Yeah, I mean, I think that could be a very real possibility, and I guess with instances like that, we would try our best to try and we would accommodate people's preferences. But I think that's a good point, that it could impact people's choices, and we would try and gather that information at the point of assessment to make an informed choice, so that people weren't too delayed to access treatment. But it's really difficult to try and balance that. But yeah, I think that's a good point.
I think it's fair to say that people's choices also include things like
where they want to be seen. We don't offer an at-home service for talking therapists. I think it's fair to say, Paula, it is clinic-based, isn't it? But some people do have preferences based on either where they live or where they work. And then some people have a preference for an evening appointment, for example, which may necessitate a longer wait. So we do adopt a person-centred approach, but it can impact. If people are more flexible, then there are obviously more options for them to be seen sooner.
Thank you. Are there any further questions? The only question I wanted to ask you, you said that there are two different telephone services. Are they just, if say, do you need an actual referral to be able to ring them, or you could just access them? Again, I'm assuming that this would be on sort of the Z card.
Yeah, so the 24-hour helplines that we offer, whether it's for children, whether it's for adults, people can self-refer to those. They are on the Z card. If people follow, I'm going to say Twitter, this shows that I'm not literate, doesn't it? It's called X and I went to, but if you follow the Kirklees ICB Twitter account, X account, whatever, or the Swift one, they regularly come up on feeds through the week to promote across our communities that those are available for people to see. So they go out in multiple formats, as well as that they're accessible to GPs and things to pass on to people. Our services pass those numbers on to people so that they're aware of them. Like I say, that they come up on Facebook regular. I think it's a blue logo that comes up, and it says Kirklees Helpline, and the number's there 24/7. So we do it multiple ways, but again, linking it back to your question, we will take that back and see if we can improve that.
Thank you, and no other questions. Can I just thank you for a very comprehensive report? I'm sorry, I don't know your name, but you should be allowed to brag, because what you've actually done is and actually sort of tangible, and being ahead and looking at the other people from outside the area are actually saying actually this model works. So be proud of what you've actually done, and thank you. We've not quite finished, Councillor Firth. Only a quick thing is just going now on to the actual work programme. Is in our next meeting we'll be looking at communities accessing care and the capacity and demand for Kirklees health and adult social care systems. We're also going to hopefully, maybe in January, because we were looking at where we could fit it in, is some joined up working with the children's scrutiny panel, looking at sort of children's immunisations, but also adults immunisations and dentistry across the board, because they wanted to take on some dentistry, and we are due to have them back. And I tried to broaden out the actual thing, because what we were asking them was more about sort of children coming in and having to have extractions, etc. And I really wanted to know what is being done to stop those kids ever needing to come into hospital. Was there anything you wanted to add, Nicola? No. Okay, then I'll close the meeting.